Good afternoon. It's a pleasure to be here. I'm David Arterburn from GroupHealth Research Institute in Seattle, and I'll be talking with you today about our work and our story behind implementing patient decision aids to improve patient engagement and to reduce costs. First, with a financial disclosure that I have received research funding and salary support from the Informed Medical Decisions Foundation and serve as a medical editor for the foundation in developing their bariatric surgery decision aid. The Informed Medical Decisions Foundation, in partnership with their for-profit partner Health Dialogue, produced the decision aids that we'll be talking about today. First, sticking with the themes for this session, I want to talk about our pathway towards shared decision making, and really there were two routes that really drove us that way. First, beginning with an overview of who we are. GroupHealth is a consumer-governed nonprofit healthcare system that integrates care and healthcare coverage for over 600,000 Washington State residents and also some residents of northern Idaho. That's about 1 in 10 patients in Washington State who get their care from GroupHealth. We have both salaried providers, which 2/3 of our patients receive their care from, and a network of contracted providers. GroupHealth was motivated by two things, as I mentioned. One was unwarranted variation. And I think you're all very familiar with the Dartmouth Atlas, and GroupHealth was very familiar with that work as well. But there had been 20 years of complacency around that because we believe within our own system that we really didn't have unwarranted variation until we actually did the analyses of our own data and found, as this graph shows, that 3 of the regions in GroupHealth, the solid lines, had very different rates of knee replacement, and that they differed actually from what the state and regional averages or rates of knee replacement were in the state here in the dotted lines, and then with the GroupHealth regions in the solid lines, we had very different regional rates of knee replacement. So although the patients we felt were the same, providers were all salaried, we had very different rates of knee replacement, which suggested unwarranted variation that wasn't in alignment with patient preferences, but maybe more likely to be driven by surgeons' opinions about treatment practices. Another key influencer of shared decision-making is that Washington State in 2007 passed legislation which recognized shared decision-making and the use of it, along with the high-quality patient decision aid, as the highest standard of informed consent for patients in Washington State. It also mandated but did not fund the state healthcare authority to implement shared decision-making demonstration projects, and GroupHealth was one of the sites that took that challenge on, and that's what I'm talking about today. In 2012, Washington State updated their legislation, giving the healthcare authority a power to certify high-quality decision aids for use in Washington State. So what were the infrastructure elements that we put in place to support shared decision-making at GroupHealth? Well, it was a system-wide implementation with video-based patient decision aids, which you've heard about previously by Jeff and his team. There were 12 preference-sensitive health conditions that we targeted related to elective surgeries, and they're listed all here. I won't go through them all, but there's 6 different specialty service lines throughout Western Washington where we're working with different specialty clinics and different specialty providers in Tacoma, in Olympia, in GroupHealth, in Seattle, and in Bellevue. We gave providers access to these patient decision aids through our electronic medical record, which was EpicCare. They could just type in SDM, shared decision making, into the order field, and it would pop up a list of all the different decision aids that they could order. They could then place the order, and that order would be routed to the patient's home through the mail, where they could watch it with a patient, with their family members. Patients could also be routed to watch the video online, so they could go onto our secure patient portal and watch these streaming videos. You can see that many of them actually are quite long, up to 50 minutes and in many cases, but patients didn't complain about the length. These are treatment decisions that they were facing. And so we had many patients, 1/4 of our patients viewed decision aids online. For providers, we also provided smart phrases. These are Epic tools which allow them to more easily document that they had referred a patient to a patient decision aid, or once they've actually referred them and they're seeing them back or having a conversation about the patient decision aid and the patient's treatment options, could more easily document that they discussed the content, documented their treatment preferences, and where they're going with their treatment services. Another key piece of this implementation package were project managers, which were critical, 3 FTEs of staff who were working with these clinics on the front line during our first year of implementation doing a plan, do, check, act process of working with providers and quality improvement in an ongoing way to meet the needs of the different providers. The endpoint there is ongoing quality improvement initiative, a PDCA process. And these project managers were critical throughout the process to understand the workflows and to get the decision aids in practice, because each practice had different workflows and work styles. This work with project managers led to streamlining of the process for both pre, during, and post-visit care, which dramatically influenced the rates of decision aid delivery. But how did GroupHealth create a culture of expectation around shared decision-making with providers and begin to build competencies for providers, which is work that we're doing? Most providers have this attitude when we first talk to them. I already do shared decision-making, but we realized that that probably looks like this. Of course, it's totally up to you, but if it was up to me, I'd choose to have the surgery. And this is the attitude that most providers actually had towards shared decision-making when we first began talking with them about it. But GroupHealth leaders really wanted to set a different tone. And it was not, this is nice to do if you have the time and the inclination, but it was more towards, no patient should undergo a preference-sensitive procedure without documented evidence that they got all the information they needed and had a conversation with their provider in which their preferences were documented before they made their decision. The key steps that were required to initiate this culture change were requiring all the providers in specialty care to review the patient decision aids that their patients were going to watch. We also, within the second year of our implementation, we had a half-day CME where we pulled all the specialty providers and the surgeons out of clinical practice and had them work with outside experts on training around shared decision-making. We provided them monthly feedback on volume of decision aids ordered, number of surgical procedures, the total cost that those surgical procedures added up to, and the number and percent of patients who had a preference-sensitive surgery who had not watched a decision aid. But perhaps most importantly for culture change, patient satisfaction data really influenced provider opinion about these decision aids, and I'll present some data about that a bit later. We told providers that we expected that these decision aids would improve patient knowledge, that it would improve their satisfaction with care, it would help us understand what's the real rate of demand for these procedures, and would probably reduce unwarranted variation in our care. But most importantly, we told our providers that we thought this was a question of patient safety. It's not wrong site surgery that we're worried about, it's wrong patient surgery that we're worried about. Where uninformed patients making decisions about surgery, it's wrong patient surgery. What were the outcomes that we observed while we were throughout our process? Well, now 4 years into implementing this work, we've delivered over 31,000 patient decision aids in these 12 different elective surgical procedure areas as of January 2013. Over time, we have dramatically reduced our defect measure, which means we have fewer missed opportunities for patients to receive a decision aid prior to going to elective surgery. This graph shows that at the beginning, 100% of our patients were going on to surgery without receiving a decision aid. Now we're down to about 35% of our patients, and these are in the areas of hips, knees, low back, hysterectomy, and benign prostatectomy, in terms of the proportion of patients getting surgery who have not had an opportunity to view a decision aid. We're not all the way to 100%, but we've made dramatic improvements over time. We surveyed patients in the first year, and this again influenced providers dramatically. 96% of our patients said that these videos were very good, excellent, or good at helping them understand their treatment choices. And 95% of them said that these were very good, or excellent in helping them prepare to talk with their provider. And we documented outcomes with help from the Commonwealth Fund to fund an evaluation of this. We've showed that implementing patient decision aids was associated with sharply lower hip and knee surgery rates and costs, where we had 26% fewer hip replacement surgeries, 38% fewer knee replacements, and 12 to 21% lower costs of care for these health conditions over 6 months. We've seen similar reductions in rates of surgery in areas related to women's health, abnormal uterine bleeding and uterine fibroids, as well as in BPH and prostate cancer. The impact on costs of care have varied by the health condition, but overall, we've seen consistent reductions in rates of surgery. Where in the case of knee and hip osteoarthritis, we're saving on average roughly about $3,000 for hip OA and $2,000 on knee OA per patient within the population. So overall, our conclusions as a result of this work is that large-scale implementation of patient decision aids is feasible in the scale of an organization like GroupHealth. And that shared decision-making really appears to be headed towards achieving really the triple aim of healthcare, where we're getting higher patient satisfaction, lower costs of care, and improving patient quality through improved knowledge. Our next steps are to add 5 to 7 new decision aids in this year. 5 we've already committed to, 2 more that we're considering. And 2 key elements that are very patient-centered. One is that we're moving this conversation upstream from specialty into primary care and having conversations and decision aid ordering being centered there for most of these health conditions. And the second key thing is that we're automating recording of patients' knowledge, their values, and their treatment choices in the electronic medical record. They can complete this information online, and that goes in the electronic medical record where the provider can access it at the point of care and have a more engaged discussion with the patient about their treatment choices. I want to acknowledge the funders as well as the many collaborators and clinicians that were involved in the work to actually get this work done, and a slew of external advisors as well. And thank you very much for your time and the opportunity to present.